fine. Thank you, Vetri. Hello, everybody. It's because the subject is end of life care. You don't have to look so grave. Still, start with a smile, please. From everybody.
Smile.
Dr. Lorna, thank you for being the leader. Upakul. Dr. Upakul. Nath. Smile, please.
Yes, sir.
Oh, so difficult. Hey, hello, everybody. We are going to, as Sridevi said, talk about some important things. Sridevi, if you can find the link for these two articles, please share it with the group and or later perhaps so that everybody can access them. Fairly recently, there were two articles. One was written by Dr. Sue Roypa, an internal medicine doctor from USA. She writes about her mother's experience and her experience. Her mother was having advanced pulmonary disease, and she went through the usual treatment. The usual treatment in our country being, if the oxygen saturation drops below 90, intensive care unit. If the serum sodium drops below 127, 188, depending on the hospital, intensive care unit, and so on. The mother was uncomfortable. At some point became restless. She was tied up. And Dr. Sue thought this was new, very well knew this was not right. She pleaded with the doctors and the pulmonologists to let her be without intensive care unit, be with the family in a room. And she begged for small doses of morphine, which you already know are now the standard for the terminal breathlessness in any pulmonary situation, including COPD. Not only was she denied that privilege, the doctors actually told her to her face, "What? You don't care for your mom? You want her to be dead?" And a palliative care unit in that city came in on her request, and they said, no, we don't give morphine for anything other than cancer. Friends, these are well-intentioned, ignorant doctors. And I hope we will not only be able to do the right thing, but also advocate for justice for people in breathlessness. The second article was published this week, in the last few days. It was published in the famous newspaper, The Guardian. It was published by a rather equally famous writer and general medicine doctor, and again, an advocate, Dr. Sanjana Srivastava from Australia. Dr. Sanjana, like Suroyapa, is another doctor of Indian origin who has plenty of relatives living in India. So she writes about her aunt, again similar situations, pleading with doctors for mercy for the person, but to no avail. So it'll be interesting reading, short reading. It won't take a lot of your time. Please manage to read it. But this will not happen to you, I am sure. And I'm giving you a lot of homework. Apart from those two articles, I'll also share with you this link. This link to the Lancet Commission report. This is the Lancet Commission report on the value of death. The Lancet Commission report of 2021. 22. The article is long, the paper is long, but you might perhaps care to read the executive summary, which is not too long. And maybe as you rush through the pages, you may need to look up 1.5 pages specifically on India. And please look at the recommendations also given there. So these are what I'll consider essential reading, because they are of now, this year and the last couple of years. Friends, by the end of the session today, these are the competencies that I hope we will have. And if anything is not clear, we'll be able to deal with that in the discussion to follow. You should be able to prognosticate death, not absolutely, not certainly. You should be able to discuss with anybody the pros and cons of giving artificial life support at the end of life in incurable situations, and the pros and cons of life support in the form of nutrition, including parental nutrition, but also nasogastric feeding and any form of hydration. Then, before we close for the day, you must be able to understand what palliative sedation is. We will not have time to discuss in detail, so that's another homework for you to do in detail later on. Understand about how to provide palliative sedation and explain how to adapt whatever you have learned during these last weeks on the medical, nursing, and psychosocial-spiritual aspects of care, so as to provide comfort. I'm sure my colleagues will be sharing the whole presentation with you so that you will have access to it. But let me start with a question. Can you please project this poll? Do this poll. Please click on what you think is the right answer. Am I causing a lot of rustling noise because of my earphones?
No, sir, it is very clear.
Okay, thanks. How many participants, Sri?
39 as of now, 21 has attempted.
Okay, some people are still coming in. Of 39, 24 is not very encouraging. See, in any virtual session, if people do not respond, you suspect that some may be having a siesta or maybe multitasking. 24 out of 39 is not very good. Well, we can't wait forever, but this is not a typical audience, a medical audience, because you are all already into palliative care. What typically happens in a medical audience is when I ask this question, roughly 1/3 of people will say yes, some 1/3 will say no, and another third will say we are not sure. But here what I see, even in a palliative care group, only approximately 50% of the people who vote are able to think about your own death. It's easy for me to ask the question at my age when I can see my death right in front of me. At your age, I know for the majority of you it will be harder. Nevertheless, at any age, let me tell you that being able to think about it, please go back home and reflect on it this evening. Being able to think about your own death is a great strength, not only for yourself, but also for your loved ones, your grandparents, parents, aunts, uncles. Because if you are not able to think about it, you will think only if the patient has them, not us. Then when the time comes for important decisions, you may not be able to take them. Secondly, especially to the 13 people of the 25 who said they are able to think about it, you may be able to go one step further now and think how you want to spend the rest of your life. You know you are mortal. You have, so many potential years in this world. What do you want to do with it? That's another benefit of being able to think about it. With that thought, I'll leave it to you to discuss now to discuss how to provide end-of-life care. This is the prognostication of death. I am sharing with you two tools. I know it looks complicated, and it is very busy slide. But imagine a patient, the one like Sanjana Srivastava shares in the article, totally bedbound, unable to do any activity, needing total care, taking only minimal fluids or sips, drowsy, or maybe confused. If that is so, her palliative performance scale, PPS scale, is 20%. Again, I repeat, this may be look a bit complicated. The slides will be shared with you. Please spend a little time. And I would recommend that you take a printout and paste it in wherever you practice end-of-life care, or have it on your phone to refer to. Now, once you have arrived at the PPS scale, then you go on to the second one, the prognostication scale. So here, with a PPS of 20%, a cancer patient has 80% chance of surviving for an average of 6 days. The range is from 3 to 19 days. But for non-cancer patients at this stage, it's the same. But you might notice that with some conditions, if the PPS scale was 30, then the non-cancer patients seem to survive longer. Please note, these scales have only 80% predictability and is in the context of hospice care, end-of-life care. Okay, remember again, only 80%. Families will come and ask you, doctor, how long does mom have? You may be able to give that if the first answer is, please sit down. This must be a big concern for you. Tell me, why did you ask this question? They may say, my brother is coming only on the 27th. I hope she will be alive. Or may they say, doctor, I have been here in this country for a whole month now. If I don't go back to USA, I'll lose my job. So people need to know. It's not because they don't care, need to know. But it also helps us to decide how we should treat the person thereafter. Here is another poll for you. Does your duty as a doctor, whatever your specialty is, to sustain life, include the duty to prolong life at all costs, including a ventilator for artificial respiration? even in a person with advanced cancer. Suppose it's advanced metastatic terminal cancer. As a doctor, do you have the duty to try to prolong life by artificial means? Will you administer the... okay, thank you. The polling is slightly better to 26 now. Notas are only 13. Thank you.
I think there are a few responses in the chat also, sir.
Okay,
One or
okay,
two responses in
okay.
the chat.
Okay. Maybe some people with coming in through a phone may find this harder to do. So anything in the chat that is relevant, Sri?
Sir, it is no. That one or two responses as no. 4 or 5 of them have responded.
So let me answer first to the 2 people who said yes and the 6 people who are not sure. That's quite a significant number, 8 people. I am making this emphatic statement and taking responsibility for this. No. I challenge you to show me a single document of medical ethics or any document which shows that your duty to sustain life means also prolonging the dying process. Friends, just as you respect life, you have a responsibility to respect death also. To make it as comfortable for the patient and family as possible, to permit as much of interaction as possible, allow the person to receive love and give love. I repeat, emphatically, the answer is no. Can you close that window? In fact, a British oncologist of Bengali origin, Dr. Sankhamitra, who now works in Australia, said, in India, the poor die in misery of neglect, the middle class die in misery of ignorance, the rich die in misery on ventilators. Friends, the rich die in misery on ventilators. The rich, for the crime of having some money in their pockets. No one gets a pain-free and dignified death. That may be an exaggeration. Maybe a small percentage of people, about 2% of Indians, may get some palliative care at the end of life. This is no way to go. Friends, from this to now on, I am talking to you as your potential patient tomorrow. I don't know where I will be at the end of my life. I don't know which one of you will be treating me. But please, let me not go this way. Lonely, inhumane, deaths with an agonizing suction catheter going into my trachea, with a tube in every orifice, devoid of all dignity. I won't be there, only my body will be. In the introduction, I must have told you Eric Castle's definition, quotation. These persons that suffer, not bodies. This woman, Sri, this was in our poor home run by the church in Kolathur. Patela. She was in a poor home. She had nothing. But for the last 5 days of her life, we could bring her daughter across. She died with some sympathy, receiving some love, with a loving hand on the forehead, some water going down her throat when the throat was parched. If God comes and offers me this rich air-conditioned death and this poor death with love, I have no idea, I have no doubt what I'll choose. Please remember, we are not only talking about me, we are talking about your loved ones also. And at some point of time, yourself. Because please note, death is the inevitable consequence of life. Human mortality continues to be 100%. And the point that why Sudha Royapa, Su Royapa and Ranjana Srivastava were particularly worried is because they know that this is not the global norm. Friends, the first image is from European countries. A study done from European Union countries, published in fairly recently in 2019, 5 years back, showed that approximately 89.6% of people were taken off life support systems in the ICU when the treatment was considered futile. Only 10% of them died on artificial life support. Contrast that with the anachronism in India. Only 30% were taken off life support. 70% continued on life support measures till they died. My brother-in-law, during the COVID year 2021, contracted COVID. He had multiple morbidities. He was only 60. And eventually, when he was dying, the doctor said, please take him to the one hospital in Trivandrum because they have extracorporeal membrane oxygenator. We took him to another hospital without that facility. Well, here, instead of the 10% in Europe where they have all the money, 70% of people eventually have to keep on existing. And the other 30% are asked to leave against medical advice. Except for about 2% of Indians, nobody gets palliative care because these people, when they were taken off life support measures, were given the alternative of palliative care. Does anybody want to make a comment or ask a question? Sri, please monitor the chat box. I cannot
Yes,
see
yes.
it at the moment.
Yes, we are there. There is a comment sometime back from Dr. Ravindra telling that this was immediately after the call about he's just mentioned death with peace and dignity.
Yes, thank you. Thank you, Dr. Ravindra. For me, friends, tomorrow, my choice is clear. I have written it down in my advanced directive. What matters to me would be a human touch and a kiss from my grandchild.
So there is a
Not,
question in the
yes.
chat from Dr. Keyur. Why is death considered a taboo topic to discuss?
Yeah, that is because, sorry, who asked that?
Dr. Keyur.
Dr. Keyur, I think it happened with the destruction of the Indian culture by the centuries of colonization and the invasion of modern medicine, which has a lot of good I'm not saying that all modern medicine is bad or anything. I believe in it. Having said that, what they destroyed was our cultural background. In Jainism, in two sects, there are these phenomena of, there are these processes of samsara and salekana, where one decides whether you have, I would decide whether I have any earthly responsibilities left. Honestly, I don't. I am ready to go. I've written my will. I've handed over responsibility of Pallium India to people like Sridevi and many others. Once I have taken that decision, with the support of elders, in the Jainism, it is the spiritual leaders. In Hinduism, there was a similar process called Prayobhavesha, where you gradually give up one item of food every week, so that in a few weeks, you would have given up all solid food. The gradual reduction prevents the hunger pangs, and gradually the person is allowed to go. We were not a death-denying society, but we became a death-denying society during those times of modern medicine, wrongly practiced. That is the paradox. They have changed their practice in Europe. We continue to do the wrong practice. So maybe we have become a death-denying society. In the beginning, I showed you the Lancet Commission report. So when you read the executive summary, you will find that they make a call for death literacy. You are illiterate. You are illiterate about death. It was a natural thing that our generation learned from joint families. Everyone who grew up in a nuclear family has not seen a death most of the time. So death literacy, what they say is discuss death in the society. Discuss it within your family. It takes courage, but it's very worthwhile. So friends, I want to now come to what I want.
So one more question. You want to take it now?
Okay.
So if the patient is dying, is young or a minor, uh, it is very difficult to think or not to try to put the patient on ventilator. In this scenario, we may not prefer dignity, but would want to prolong the time and give a chance.
Please make a note of that.
Sure,
I
sir.
think this question had better be answered at the end.
Yes, sir.
And please note who the question came from.
One more question from Dr. Dilip. Is there any reference material in the ancient India how palliative medicine was done or how death was handled?
Sri, please make a note of that question also.
Yes, yes, sir.
We'll, with everybody, we'll share some links for the Jain customs as well as the Prayopavesha.
Yeah. Okay.
I don't have that ready to hand. I'll have to search it but I'll do that. Will you please send me a
Sure,
email
sir.
or WhatsApp message reminding me to do it?
Yes, sir.
So, Dr. Cordero, Dr. Marina, Dr. Soma Datta, if I am coming to Goa and having my celebrate my end of life, please make a note of it. You may well be my treating doctor. Please concentrate on my comfort and peace. Not only talking about my physical peace, comfort, emotionally, socially, spiritually. Dr. Lorna, at that time, please sit beside me. Please lay a hand on my hand to convey that you care for me. And ask me, how do I feel? Find out from me what are the relationships that are important to me. And Dr. Lorna, at that time, I may confess to you that I wish I hadn't quarreled with my brother 7 years back. We haven't talked to each other in 7 years. In that case, irrespective of all your degrees and medical knowledge, please take the initiative for someone to call my brother and say, your brother is near the end of his life. He wants to see you. Because for me at that point of time, that would be the most precious thing that you can do for me. And allow me to leave a legacy. If my children in USA cannot see me, if you facilitate or your social worker or nurse facilitates recording of a final video telling them I love you, that will also be leaving a precious legacy. But all that will be possible only if you have physically made me comfortable. If I am in agonizing pain, I have no mind space for anything. If I am breathless and struggling to take a breath, I have no mind space for anything. That's why we have put physically always first. So thank you for agreeing to take care of me. The poll, sorry, that is poll 3. Not in his position, my position, end of life. If you yourself are in that position at the end of life, I know there are some people who are unable to think about yourself. Would you like total parental nutrition? Can you administer the poll? Nasogastric feeding. IV fluids. Oh, if that poll has not been prepared, my mistake. In that case, it's okay. You can think about it.
Maybe you can put it in the chat. We can read it out.
Maybe if I do that, Sri, as usual, I'll overrun time. But friends, let me tell you, for heaven's sake, if I am at the end of my life, what will you achieve by giving me that parenteral nutrition? All those proteins, fat, and carbohydrates which my cells are unable to use. You may still prolong my life, but remember that's also prolonging my suffering. Nasogastric feeding. If I am hungry, if I have an obstruction in the esophagus by my cancer, but I'm saying I can't bear this hunger, then I need nasogastric feeding. It should be to relieve hunger. At the end of life, normally, hunger vanishes. I may just ask for some sips of water. IV fluids, if I am getting dehydrated, and that is causing symptoms, for example, delirium is worsened by dehydration. Then, not IV, friends. Please give me subcutaneous fluids if I cannot swallow. If I cannot swallow subcutaneous fluids, please. Is this the last session, Sri?
So we have only one more session on opioid availability, but otherwise, yeah.
Oh, I know it is on opioid availability, but nevertheless, if subcutaneous hydration has not been discussed, please send them some reference about it.
Sure, sir.
We can't take the time to discuss in detail unless there is time during the discussion. And if it is not included in the curriculum for FCPM, please let us make sure that it's included in future. Soma, did you ask a question? I earlier asked, do you have a duty to prolong life? Here is the official document of your duty of care. As a physician, your duty of care in India is to mitigate suffering, to cure sometimes, relieve often, and to comfort always. There exists no exception to this rule. You certainly have a duty to relieve suffering. When cure is possible, you have a duty to do that. But if not, comfort always, mitigate suffering. So when I am lying there in that bed, if you are looking after my comfort, you are treating my pain, you are treating my delirium, you are treating my respiratory distress. But please attend to simple things. Even in the last week, a pressure sore will cause me suffering. It is amazing how intensive care units, which give great attention to the oxygen saturation and carbon dioxide tension in the blood, allow pressure sores to develop and cause pain. But at the same time, being too religious about it and every 2 hours changing, you may have to change it. Because at the end of 2 hours, the nurses may find that I am finally getting some sleep. You may allow it for a bit longer, but you will care for my skin. And as I said, artificial hydration is only if dehydration causes symptoms and one is unable to swallow. And if artificial hydration is necessary, give subcutaneous saline rather than intravenous fluids. For medicines, except for antibiotics, almost all the medicines that will be required at the end of life, including opioids and antipsychotic medicines, can be given by rectum. The problem with IV is that at that point of time, the veins get phlebitis very easily, the limbs swell up, and that becomes another source of suffering. And because it is not easy to get at the vein, then your team will come and poke me all over the place and eventually try to cannulate my jugular or subclavian vein, which is additional suffering. Thereafter, I can't even move my neck and see my son when he visits for 5 minutes. Will somebody please read it for me? A volunteer, so that I can take some voice rest. Varsha, Ahmad Yasin, Urusa, one of you, will you read it out? Unmute and read. Thank you, Varsha.
Even on the
Yes.
Even on the day of passing, a specialist recommended a liver function procedure. When asked if it would end the coma, the answer was in the negative.
This former financial advisor to the Prime Minister was writing in the Financial Business Standard about his mother. Advanced coma. The doctors had already said nothing can be done, she is dying. But still, on the last day also, they were poking her vein to do a liver function test. Why on earth? We have to think, why? If the ICU protocol says you have to change, do the chemistry every day, take the person out of the ICU, or even otherwise, have a humane protocol. Why do people have to die even on the last few days with multivitamin tablets and statins? So common. So many tablets, atorvastatin also. And even when the blood BP is down to 90/60, continuing the antihypertensives. Review the medications. And as far as possible, avoid invasive procedures. There are some that we will have to do. If there is an ascites, you will tap it. If there is a pleural effusion, it must be tapped whenever it causes discomfort. But nothing that is not essential. Antibiotics only if they are needed for well-being. Avoid not just to satisfy a culture report. Avoid hospitalizations, particularly in the ICU. But it will be my choice whether I want to be at home or I may not feel safe to be at home. And Dr. Kurt or Dr. Raisa, I may want to come to you because I trust you. And I'll want to be in the hospital room with my family. A surgery, very, very rare. You didn't want to do a tracheostomy at that time. But you may do a colostomy if my abdomen is so distended and that's causing me distress. You treat me, not the tumor, because I am dying anyway. But if I have severe bone pain and your morphine is unable to deal with it, give me a single fraction radiation. The other things I have already said. That's about the body. But I am not only my body. I am this person. If you have the time, hey, if I needed a tracheostomy, you would find the time, wouldn't you? Please sit beside me. And if I am not too sick in the last few days, early enough, please find out. Just listen to my story if you have the time. If you don't have the time, you are the busy doctor, get me a social worker or a nurse who has some time to sit with me and listen to my story to find out what connects me most to this world. For many people, it's their home. If I had the time, I would ask you. Many of you will say it's your family, but some will say it's your profession. Some will be say it's really the tree that I see outside my window. And as far as possible, keep them connected. And think again, your elderly parent is in the village and you are worried about him or her. Almas, Rusa, Manode, please remember this. Because you think they are not safe living alone, you drag them to your city and they lose their world. Within 48 hours, they may get delirious. And if I feel you safe and caring enough, I may want to recount my story. Doctor, I wish I had. I wish I had not. Listen to my story. Validate the positives. Validate my achievements. That may make me feel somebody cares and my life has not been in vain. If I feel guilty about you had told me that you had asked me to get my investigation done. I dilly-dallied and waited for a whole month. Now I am feeling guilty about that. Because of that, I am incurable now. And my children are losing their dad. Validate that. I see that you are guilty. And that is giving you a lot of heart. There's no point saying you shouldn't feel guilty. But maybe you realize that most people in your position would have done the same thing. Okay, that's enough. And by all means, acknowledge the achievements. I truly admire you. You had nothing in your childhood and you built yourself a life. You built a life for your family. You gave an education to your children. I have great respect for that. And sometimes, as I talk, friends, this is important, I may stop talking. Sometimes I am processing things in my mind. Don't rush me. If you have the time, if you don't have the time, find someone with the time to do it. Sometimes you have to respect silences. If you will come and sit there, even when I am not talking, you are not talking, it means a lot to me that someone truly cares, gives me companionship. Who is the volunteer to read it? Somebody else other than Ahmad, please. I don't know how many of you follow the cartoons. Winnie, the Pooh and the Piglet. Two great companions. Volunteers, please. Hey, last time somebody had started to read and then was interrupted. Thank you.
Today was a difficult
How do you
day.
pronounce your name?
Sir Atasia.
Atasia. Thank you, Atasia.
Yes, sir. Today was a difficult day, said Pooh. There was a pause. Do you want to talk about it? Asked Piglet. No, said Pooh after a bit. No, I don't think I do. That's okay, said Piglet. And he came and sat beside his friend. What are you doing? Asked Pooh. Nothing really, said the piglet. Only I know what difficult days are like. I quite don't feel like I'm talking about it on my difficult days either. But goodness, continued Piglet, difficult days are so much easier when you know you've got someone there for you. And I'll always be there, always be here for you, Pooh.
Thank you,
Sorry,
Atasia.
sir, the print is too small.
Yeah, I'm sorry, Atasia, about the print, but thank you for reading it so poetically. You made it come alive. It is important to give companionship. It's sometimes more valuable to be silent than to keep on talking. Respect silences. This is part of spiritual care. It is not necessarily about preaching about God. It's about respecting people also and being non-judgmental. Have you put this poll in?
Yes, sir.
Thank you. See, these are so very variables. Nothing is right, nothing is wrong. You are different from others. You are yourself. Upakul is different from Vince and Krishnat. Different individuals. And what your priorities change. This is part of spiritual evaluation and support. Find out what is important for the person. Very recently, a person with advanced cancer was seen by a friend of mine, a palliative care physician in UK. And in the last week of life, she was flown home to a place near Idukki in the hilly terrains of Kerala, where hardly any palliative care facility was available. She made that journey, lived there for the last couple of days. We could help her only with telehealth, and she died there. That's important for her. And please remember the majority, the family. You will think again before putting somebody in the ICU at the end of life. The most important thing. And if somebody wants last communion, go to any length to facilitate it. Or whatever spiritual practice they need. Reading the Quran or Bhagavad Gita is to be done if that is what gives the person comfort. I really came across somebody who said, so they thought I was dying and went on this chant. I had to ask them to stop. And please understand that for some people, the occupation is the most important. No sense saying that, hey, at this stage of life, you are already. This happened to my friend, a pediatric surgeon. He was 74, and he said, if I cannot operate, I don't want to be alive. No sense in arguing with him and saying that this is the time for you to take rest, enjoy your family, etc. Just acknowledge that and see if there is anything that he can do, like his colleagues asking him for doubts regarding a surgical procedure, a process that will make him come alive. Okay, going on, moving forward. Volunteer to read this, please.
My 84-year-old father, my best friend, was enduring raw, intrusive medical procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized.
So you will think again before submitting a dying person to this kind of treatment. This lady heard about palliative care in the last day of his life, promised to take him home the next day, and unfortunately, he died that morning. And she still lives with the pain, guilt, and suffering. And she is very angry with the medical profession. And for those who thought that you have a duty to prolong life at all costs, or those who didn't know, this is from the National Cancer Grid, the collaborative of more than 300 cancer institutions in the country. And together they have said, do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. And please note, if you withdraw artificial life support in that situation, it is not euthanasia. Euthanasia is killing. Withdrawing artificial life support is only allowing natural death. Though the Supreme Court of India used this word, our academic organization, Bioethics Unit of ICMR, says this is a misnomer. Passive euthanasia cannot be passive. It is killing. That is illegal in the country, though there are many countries in the world, all high-income countries, which have legalized this. And here is a bit about palliative sedation. So if you are unable to relieve the pain or breathlessness with whatever you have learned, the person's suffering is continuing. Then at the end of life, it is permissible to sedate the person and sedate the person till death sometimes. And that is to be done in intolerable suffering, in refractory symptoms. 1 second. In 2023, last year, in January, the Supreme Court came up with a ruling saying that advanced medical directive or living will is legally valid. So it's my protection against intensive torture. I have signed a document expressing my wishes. I have named my nephew a lawyer to take surrogate decisions for me if my wife or children are unable to do it. Now, you doctors have the ethical and legal duty in India to respect my wishes. I know that I cannot go to court against you once I am dead, but this is your duty. Please remember that. The court has unfortunately laid down some rules. If you have already started a artificial life support measure, before withdrawing it, you have to go through a process. The hospital has to form a board of 3 doctors, which can be done in a few hours. But then we have to inform the district medical officer and have an external board also. External board also can be doctors within the hospital, but the naming in the doctors has to be done by DMO. This becomes impractical, which is why particularly I want to be spared of this agony by withholding unnecessary artificial life support. So age is not important. Death can come at any time for anyone. I would recommend that you and your loved ones should create this advanced medical directive. All that is necessary to make it valid is to countersign by a gazetted officer. Keep a copy with your medical records. Most importantly, make sure that your family agrees. This is the way I see the barriers. Doctors see their duty as prolonging life. The family pressures come in, social factors, and sometimes legal lack of clarity are all barriers to end of life care, rational end of life care. So we need not only to do the right thing, but also talk about it, write about it, and be agents of change. Thank you.
Thank you, sir. We can take up a few questions before the presentation today. If there are any questions to Dr. Raj?
Anything on the chat box?
Till now, nothing other than the two questions we discussed.
One question, sir.
Yes, Dr. Dilip.
Sir,
Sorry, what's your name?
Yasin, Ahmad Yasin.
Okay, Dr. Yasin.
Sir, where can we find this advanced medical director for writing this will? How can we access these things?
Sri,
Yes, sir.
that was put in, the latest was
Yes.
put into our website last
Yes,
week.
yes,
Please share it with them.
yes.
Both the link right away
Very
and
good.
also to the group.
Sure.
It is there on our website, Yasin, and
Okay,
Sri
sir.
will share it with you.
Okay, sir.
I'm glad you asked the question for everybody's information.
There is another question in the chat, sir, by Dr. Dilip. How many times the family pressure to do things for patients just because of society image?
Yes.
So I want to just take this question. So many times what happened is just because of the image they want to create, that they did the maximum thing for the patient, irrespective of the outcome, just to keep their image in the society that they have done their best.
Very correct, Dr. Dilip. But more importantly, very often, it's because people haven't thought about it and think there are two kinds of love, Dilip. The selfish love, I can't let my mom go. The more unselfish love is, my mom is suffering so much. If her time has come, let her go. So people need time to think about it. But you are very right, because the extended family, hey, why are you not taking him to such and such place? Why are you not taking him to Apollo? You want to save money? People can ask us very cruel questions. So, Dilip, what we need to do, don't wait for the last moment to initiate the discussions. These discussions have to happen early. I'm already recommending too many things to read. One of my colleagues, who manages our website, Gina, actually wrote an article in the Hindu Online or Indian Express, I can't remember. I have the link. She said she was reading Atul Gawande's Being Mortal and told her mother, Mom, when I die, I don't want this and this. I want that and that. The mom immediately said, of course, I also want it that way. I don't want this, etc., etc. Then she went to her dad and said the same thing. And what she says is, these are not new thoughts for them. The people have thought about it. But she was raising the question when she was healthy. And that's the healthiest thing to do, discussions early. But unfortunately, many people are death denying. They think it is inauspicious to think about death. That is a problem. So Friends, when I wrote my advance directive, I told my wife, she was okay with it. I talked to my sons. My one son immediately said, okay, cha. That was it. The other said, why are you talking like that? Why do you want to talk about these bad things? You are perfectly healthy now. Nothing is going to happen to you. He was saying that out of love. I actually took him to he listened to a lecture by another palliative care physician on end-of-life care. And as he was driving me back, he said that now I understand what you're talking about. It's okay by me. Please remember, whatever you have written, unless the family agrees, cannot be done. Doctors know that dead people do not go to court, but living family members go to.
So there are a few more questions in the chat. One is, should we give CPR to gasping palliative care patient?
Absolutely not, absolutely not, absolutely not. 3 times in capitals. That's a vulgar corruption of medical practice. Give them respect. I found a humane practice in Sevagram in the medical college, practiced by a professor of medicine. So when somebody is in that situation, the available doctors go there. Let the family be with them and stands behind them, bowing and being with the family. But that's easier if you have discussed in the past. Sri, I know that I have talked too long and
No, sir.
exceeded time.
No, so there is one more important question that I think we should take now before the case presentation, if that is okay. So Dr. Kurt has written that he has a 7-year-old child with on end of life care with maxillary RMS. Child is hungry, but due to swelling of the tumor, she cannot take anything orally and cannot open her mouth more than 2 centimeter. Though a child,
Huh?
yeah, though a child, she has stated she doesn't want any tubes or anything. She is on morphine and paracetamol already, but poor pain tolerance. Would it be ethical to put a tube as she is hungry, or would it be right to sedate her?
7 years old.
Yes, sir.
At 5 to 6 years, children understand the irreversibility of dying. They can understand. It's important to get the child's opinion. What do you want? I'm hungry, give me food. We can. That will mean we'll have to put a tube in. We'll try to do it as painlessly as possible. No, I don't want a tube. Why is it that you don't want a tube? Are you afraid of the pain? In which case, let us try to put in local anesthesia so that the pain will be least. Because there we have only these two choices. If we don't put a tube, you are going to be hungry. The child may still say, I don't want a tube. Okay, then respect that. But keep offering that after 12 hours, not every hour. If you are very hungry, will you let us put a tube in? But the child now chooses between hunger and tube, and that's the child's prerogative. But the family, you'll have to support the family to go along with the child's wish.
There is another part to the question. Probably, I think I'll have the clinical team to have a talk with Dr. Kurt on pain management. She is on morphine and paracetamol, but inadequate pain control. So,
Sri, did we do a session on management of difficult pain for
yes,
this
sir.
woman?
Yes, we did.
So maybe, I don't know whether Dr. Kurt was not there at that time. If not, can you share that presentation with Dr. Kurt?
Yes, sir. And I'll also let one of our telehealth person to have a call with him so that.
Yeah. So, Dr. Kurt, there is only 3/4 of all patients will have pain relief on morphine and paracetamol. One-fourth may require other measures, which are the 10 steps that we described in difficult pain. Sri, did I do the session or did somebody else?
Sir, it was done by someone, not by you, sir.
Okay, right.
We'll move on to the case presentation and we can take up more discussions based on that. Dr. Ahmed?
Yes, ma'am. Can I start the presentation, ma'am?
Yes, please go ahead.
Good afternoon, everyone. I am Dr. Ahmed Yasin. I am from Kerala, Wayanad district. I am practicing in the anesthesia department in Dr. Mupan's Medical College. We have a palliative medicine department also here. We'll move on to the case now. My patient was a 65-year-old male. He was diagnosed to have carcinoma stomach stage 4 with liver metastasis. He was having gastric outlet obstruction, reflux esophagitis, and there was also a feeding jejunostomy done for him with tube in situ. Presenting complaint of the patient was severe abdominal pain since 1 week, multiple episodes of vomiting, foul smelling vomitus, constipation since 1 week. There was altered sensorium and decreased sensorium intermittently for 1 week. And while on admission, he was also experiencing recurrent episodes of hypoglycemia for the past 2 days. History of illness: he was diagnosed to have CA stomach in January 2024, has not taken any chemotherapy or radiotherapy. The subsequent scans showed liver metastasis. Patient then developed melena and coffee-colored vomitus. He was found to have HB hemoglobin level of 5.7 and blood transfusions was done. Endoscopy was done in April 2024 by gastroenterology department and was referred to the gastrosurgery for feeding jejunostomy insertion. Laparoscopic feeding jejunostomy was done under GA on 12/4/2024. The patient tolerated the procedure well. Patient then was admitted under palliative care medicine department with complaints of severe abdominal pain, multiple episodes of vomiting and constipation. Patient also had recurrent hypoglycemic episodes and was put on 25% dextrose infusion at the rate of 20 ml per hour. Patient then was shifted to the high dependency unit from ward on the bystander's request. On examination, patient was conscious oriented at the time of examination, was afebrile, pulse rate was 80 per minute, respiratory rate 18 per minute, BP of 100/70 millimeters of mercury. Abdominal distension was present, pallor was present. Patient was in proper position. Abdomen was grossly distended, even bowel sounds was present. Dilated veins also was present. Respiratory system rate varied between 18 to 26 per minute. There was increased work of breathing and bilateral crepitations. Basal crepitations was also present. Treatment and investigations: HB was found to be 8.3. Platelet count of 1.4 lakhs. Total count of 10,520. Serum creatinine was 1.8. Sodium was 125. Potassium was 5.2. Endoscopy done under sedation showed CA stomach with gastric outlet obstruction and reflux esophagitis. Laparoscopic feeding jejunostomy was done. Supportive treatment with O2 support, glycemic corrections, and electrolyte imbalance corrections was given. Psychosocial aspects: he was married and having 2 male children. Elder one of 38 years old working in a private company in Bangalore. Second one 33-year-old doing agriculture in their native place, which is in Wayanad district only. 59-year-old wife, she is an housewife staying with him, middle class family. Patient was initially not having any knowledge that the symptoms he is having is due to the CA stomach. The attenders needed time to disclose the information, but patient was keeping on insisting why the feeding jejunostomy has to be done. That time they have to disclose this information to the patient. Initially, he was into a depression, but was motivated by the attenders, and also I have to especially say by the hospital staff. And they were in an accepting mentality regarding the present condition. Was bedridden for the past 1 week. Wife was very much depressed to the extent that she was not even going out of home or even to the church after the diagnosis was made. Medications given morphine initially he was started on 10 milligram fourth hourly for 4 days. Then it was converted to IV infusions. IV fluids for electrolytic imbalances NS and RL was given based on the IVC assessment. Potassium supplementation, Portchlor 10 ml TAD was given. DVT prophylaxis was given. 25% dextrose infusions was started for the recurrent hypoglycemic episodes. The hypoglycemic episodes, while I was taking the case, it was seen as 29. It was varying between 29 and 70 milligrams. Amitriptyline was given. Pregabalin NT and bisacodyl tablet was also given. Main concerns regarding the patient was that severe pain, the abdominal distension, vomiting, and depression, which he was going through. Summary: 65-year-old male with diagnosis of CA stomach with liver metastasis, feeding jejunostomy tube in situ with severe abdominal pain, now terminally ill with abdominal pain, vomiting, constipation, and altered sensorium intermittently, and recurrent hypoglycemic episodes. The discussion points I would like to add in this case is how to deal with the total pain in this patient, how to deal with the feelings of the relatives, what advanced care planning can be done for this patient, and how to provide end-of-life care support for this patient.
Thank you, Dr. Ahmed, for bringing us the story of your patient with cancer of stomach who is going through the end-of-life situation. I would like to ask other participants, would you like to know more about this patient, or is there any comment that you would want to make for Dr. Ahmed's patient? Either you can take one by one. How will you deal with the pain and the feelings? How will you deal with the family? Well, I'll wait for the chat. Anyone would like to unmute and talk?
It takes social worker support.
Thank you for breaking the silence, Dr. Raisa. Would you like to add a few more sentences? Like, why do you, or what support we can extend?
For total pain, it's mentally.
Okay. Dr. Ravindra is telling family to be counseled regarding the prognosis. Dr. Ahmed, what kind of conversation you might have had with the patient and the family, and how much they are aware of?
We have an MSW department here in our hospital. We have social workers who comes to rounds and take care of all the social needs of the patient here. So bystanders, after the endoscopy itself, we have explained about the condition to their sons. Both sons were present at the time of diagnosis. So they were in an accepting mentality initially itself, but they were having the fear regarding how to disclose this information to their father, because they were not sure in what mentality he will be taking this. Will he go for depression, or will he be in an accepting mentality? Though they kept on insisting to us that please delay in disclosing the information to the patient, as they need time to discuss with the other family members regarding how to disclose this information. But patient was keeping on asking during the feeding, while he was posted for feeding jejunostomy. he was repeatedly asking why the procedure is being done. That time, we have to say that the social workers department actually talked with the bystanders and the patients separately, and the bystanders were then ready to disclose the information to the patient. And during the before while doing feeding jejunostomy, the information was passed on to the patient, but he was not in an accepting mentality initially. Then after the procedure, he went to depression. He was not ready to talk to anyone like that. Then slowly he was into an accepting mentality. Our social workers were repeatedly in contact with the patient. Every time we come for rounds, they also come along with us, and all the needs of the patients was met during that time. Total pain. He was asking the question that spiritually will he be able to go to church with this feeding jejunostomy tube, even if he is discharged from the hospital and all. That was the main concern for the patient actually.
That's a very valid point and exploration by your team. And how did currently he is in your hospital or he is at home?
He is at our hospital now. He is at the terminal stage actually.
Okay. Just one more question. Sorry, Dr. Ahmad. Based on today's discussion, would you like to reconsider any of the medications that he is currently on? This is a question to everyone else, not just to Dr. Ahmad. I would like to see some responses. Would you like to alter or reconsider any of the medications that he's currently on?
His pain, he is tolerant to. It is decreasing with the morphine dosage actually. So I would like to continue the morphine dosage, but no, do not go for any aggressive treatment options.
I'll just go on to the treatment. Yeah, just so that we are on the same page. So just wanted to see, would you like to reconsider any of these medications based on today's discussions? So you told you would like to continue morphine and the pain is pretty under control. And what about the IV fluids and potassium and dextrose and the heparin?
He was having altered sensorium intermittently.
Okay.
The patient was admitted to the private room only initially, but the bystanders requested that that they cannot see their father in this condition like that. On their request only, we have shifted to the high dependency unit. IV fluids can be withholded if needed.
We can change the route of administration of some medicines in this.
So Dr. Raisa is saying maybe we can reconsider the route of some of the medications. Thank you for that. There are certain comments also regarding sedatives, maybe adding sedatives. And Dr. Upakula is asking how long the medications to be given to the patient. That is another thing that we need to discuss or within your own team, that like we were discussing in today's session about we have to prioritize which medications do we actually need right now and how long do we need to continue these medications. How long are we going to correct the potassium and how long are we going to prevent the deep vein thrombosis. So maybe it is, I understand that he was depressed initially, but now you and your team feel that he is more accepting, probably, right?
Yes,
Maybe it is the right time to sit with him and ask, like we discussed, what does he want? Time may be a little short, right? What does he want in his life? What are the priorities? He already mentioned he wants to go to the church. Will it be possible to have a visit to the church? Arrange a volunteer, arrange a vehicle.
Yeah,
He'll be still admitted in the hospital, but if there is any, or there are people who bring in priests to the hospital to have some prayer which they believe in.
Yeah,
So
we do that, ma'am. We do that.
these are the points which will be very meaningful for the patient, because rather than medications for them, it means a lot to have a prayer or have a visit to the church, or probably just talking openly about his own fears. Initially he was depressed, he was not talking. There might be a lot of fears with all the procedures, and long time he was kept away from the diagnosis. There is a lot of uncertainty about the future. How is it going to be? Maybe they'll open up with simple points like, is the death going to be really painful? Will you take care of the pain if it is too much? Or will I be breathless while I am dying? Is it going to be very distressful? So these are some of the areas that patients need, or the family needs some answers, but we don't know what he is thinking. So it is, the best thing is to, every day when you go for rounds, sit with the patient and explore more. What is it that is most important for him and his family? What is it he is very scared of, or is there anything that he's uh, scared of or concerned when he's thinking about the coming days? These are a few thoughts that I had. And as you said, maybe asking about the place of death, probably. Would you like to be at home, or would you like to be still continue with us in the hospital with minimal intervention? And if this happens, how would you like to proceed? How would you like us to proceed with? So all these questions can be asked, but gradually, and explaining what it means, than just giving like a menu. They may not
Hmm.
understand with lot of questions, maybe one point at a time, not everything together. But it should be coming naturally during the conversation than asking questions directly. Even if you sit with them and don't talk also, sometimes they come up with a lot of anxieties and issues, or sometimes good thoughts. It will just they'll just start sharing, and those will be very, very important points to address. Sir, any comments from your side? Sir, sorry, before that, before I forget, I want to address the vomiting and the constipation and the abdominal distension part. All these symptoms look very much like a bowel obstruction. So if you go back to the session on bowel obstruction, you can see the regime, how we can manage with steroids and other
Yeah.
drugs. That might work really well at this point of time. It's worth a try. If you have any queries regarding that protocol, just get back to us. We'll help you.
Sure, ma'am.
Yes, sir.
Ahmad, so happy to see that you have a good palliative care team and so much work is being done.
Thank you. Thank
So
you, sir.
happy to see that. Mm. I love coming to Wayanad. It's a beautiful place. So who knows? I may be one of your clients someday. Uh, many questions, Ahmad. Very often you come in as a palliative care physician a bit too late. For example, the feeding jejunectomy was already done. Maybe if you had got involved earlier, you would have questioned it. Is it in the person's best interest?
Yeah, sir.
And secondly, as Sridevi said, hey, everybody, it's amazing how much of suffering can be caused by constipation. You talk about various causes of gastrointestinal obstruction, but especially at the end of life, when food intake is poor, fecal matter is hard, impacted fecal matter causes a lot of suffering. Generally, you are able to identify it by auscultation alone more than anything else, and maybe by ultrasound, seeing all the hard fecal matter impacted and treating that is so important. And except for palliative care physicians, nobody else seems to take constipation seriously. A tumor gets attention, but impacted fecal matter gets ignored. That is another point. Uh, can you put that, bring the questions back into the screen? About the hypoglycemia, Ahmad, did it
Yes.
cause consciousness at any point, or it was only confusion?
Confusion, sir. Confusion only.
Okay. I asked because specifically, if the patient is confound deeply unconscious in this situation, please remember that treating the hypoglycemia will be causing suffering.
Yeah, sir.
But uh, uh, the family, of course, they want time. We cannot expect a reaction from them within half an hour.
Yeah,
It's such a difficult decision, which is why it's important to start decisions early.
yeah.
24 to 48 hours is what they need, usually. Even then, there will be conflicts between family members.
Yeah.
And then you will have to facilitate family meetings. So one of the important things is to make sure what the person wants. And then at some point, he may gently says to the son, look, your father has a wish, a last wish in a way. This is what he wants, and what you are suggesting may actually be denying him of the wish. And one thing that I frequently do to families early enough, before we talk to the extended family about this, you will have to make up your mind that you will do what's best for your dad, not something to please the uncles and aunts, because that's often a problem. They'd be critical. They won't understand. Ahmad cannot spend time with all the extended family. So generally, if it is put in some way, that way, early enough, the children may come to a joint decision. So whatever others say, we will do the best for him. And then that's easier. Advanced care planning. Earlier, somebody asked about CPR. My God, CPR would be a vulgar application of modern medicine. CPR is important when you can has a chance of bringing somebody back to reasonable quality of life. Here, it is a strict no-no. Any other specific question, Ahmad?
Nothing, sir.
Sri, any point that you would like me to
This,
specifically bring? Yes,
this
Ahmad.
2 days back was he was not on any police catheter or nothing. He was self-voiding only.
Mm,
Patient 2 days back had along with his constipation history had urinary retention also.
mm,
That time we arranged for an bedside ultrasound.
mm,
It showed BPH also.
mm,
It was but patient we did not aggressively emphasize on the need for Foley's catheterization as he was in palliative care. Our actually we 5 doctors are there looking after the palliative care department here.
mm,
3 of them are anesthesiologists and 2 are from the general medicine department
mm,
who has done this foundation course.
mm,
So they told that it's up to patient's wish whether to put Foley's or not. Actually,
mm,
we patient was not ready for Foley's catheterization during that time.
mm,
Actually, it was not complete retention. There was
mm.
some mild flow, but severe collection was there. Post-residual volume was there in the scan actually. So we did not do Foley's catheterization for that patient, respecting his decision.
So in this situation, our aim is to improve is the best quality of life for the patient. What I would do is I'll try tamsulosin. I don't know whether you have already tried that.
Yeah, we have tried, sir. We have.
Okay. And if that doesn't help, if the patient is not distressed because of retention, it's okay. But if the patient is distressed because of retention, I may put in a silicone catheter first rather than indwelling catheter. See if avoiding is permitted once, then you may not need an indwelling catheter. And maybe a reduction in the dose of. Here I saw also amitriptyline being given. At this stage, I don't know if that is still needed because if the lifespan is only a few days, maybe less than 5 days, maybe it is pointless. But the combination of morphine plus amitriptyline could be the reason. Oh, at the advanced age, everybody has a BPH, but it was that was not causing a symptom till the previous week. So if relieving the constipation doesn't treat it, we may try to reduce the dose of morphine and skip the amitriptyline for a couple of days after giving one silicone catheter insertion, because an indwelling catheter may be distressing. But as you very correctly did, it was the patient's choice. Good.
Sir, I have one more scenario to deal with, sir. It is related to my uncle actually.
Sri, you decide whether this should be part of the discussion or should we close the session and then take it up with Ahmad.
Yes.
I know that we have exceeded time.
Yeah.
And I don't know if anybody else wants to ask anything. Ahmad, don't go away. We'll discuss that. If anybody else wants to stay on, they're welcome to. But Sridevi may want to close the session because the time is.
So thank you, everyone. We'll continue discussion with Dr. Ahmad. If you want to stay back, we are happy. But otherwise, we can close today's session, and we'll see you again on Monday. Please make sure that you attend Monday's session because it is very important, and we are having a lot of information being conveyed on Monday on opioid availability. Thank you so much.
Yes, Ahmad.
Sir, my uncle is actually my mother's brother. He was diagnosed to have CA lung 1 year back. We took treatment from Malabar Cancer Center, Talasheri. Almost for 1 year, chemotherapy and radiation therapy, everything was done. Last week we did a repeat scan.
Sri, can we close the screen share so that we can see Ahmad better?
Yes.
Okay.
Sir,
yes.
uncle was diagnosed to have CA lung 1 year back, sir. He was treated from Malabar Cancer Center. He was treated with chemotherapy and radiation therapy. We took a second opinion from Tata Memorial also. They insisted on the same chemotherapy, even it was deemed inoperable. The mass was deemed inoperable. Now, actually, last week we did a repeat scan. It showed that it has increased in size actually, the mass. So we took the opinion of the oncologist from Malabar Cancer Center. They said that there is no point in treating with chemotherapy again, as they have tried different combinations before itself. So we are planning to discuss this. The patient knows that he is having CLN, but regarding calling off the chemotherapy and other treatments, we are going to discuss with them day after tomorrow.
But Ahmad, what is his level of acceptance?
Initially, he was not accepting at all, sir. It took a lot
natural, yes. But
it
now,
took a lot of time to make him understand the situation. Now he's following all the treatments correctly, but we have not told that the repeat CT has showed that repeat scan has showed that mass has increased.
So, Ahmed, what I'll do is to sit down with him. I don't know why, after he has accepted the incurability, you are still holding back some information.
Special type of character. He will ask all those options. He himself has his friends everywhere. What all options he can take.
Yeah, so but Ahmad, there is a basic thing. Whatever type he is, it's his life. He has a right to know the truth. If he wants to know, you have a moral responsibility to tell him. Then explore his options. Who knows? He may ask around several people, and some people may advise chemotherapy. Especially what very often happens is people have connections in USA. They have an uncle who may not be an oncologist. The uncle may be in public health or biochemistry, they will ask the uncle, and the uncle will give an advice what he thinks or she thinks is right. And for them, that's the final word because it came from USA. This is a frequent scenario. But then you could tell him, yes, I understand that you still wish to give chemotherapy, and if it's your decision, but that is provided the oncologist is willing to provide it. If the oncologist thinks it is wrong, he, she may or he may not be willing to do it. That's also right from his side. No, because the patient wants, I have no right to give any, I have no responsibility to give any inadvisable medication. So if I clearly know that the chemotherapy is harmful, then we may decline to do it. Sorry, we genuinely feel that the chemotherapy will do you harm. So I don't think we can do it. And it's up to the patient to go elsewhere, of course, in that situation. But as far as possible, please, you instead of saying I won't give it, I want you to think again. 3 days is not going to make so much of difference. Please give it a think. If that is more likely to cause worsening, give them time to think and come to terms. And in the meantime, talk to him about other things. If you are not sure, sometimes that happens. You think chemotherapy is going to be harmful, but maybe who knows? Sometimes it may still help to extend his life, and that may be what he wants. In which case, you will say, okay, let us do one thing, as you are keen. Let us do one more, give one more chemotherapy. If you feel better with that, we'll continue it. And very often, after that, he has had time to think about it. They may say no. So rather than a breaking point, no, it's harmful, we will not do it. Sometimes it's good to negotiate. It's called shared decision making. You and they do a decision making together.
Okay, sir.
So very glad to hear that you have 5 doctors in the palliative care team. That must be quite a large department.
Yes.
Oh, so happy to hear that. Who is
What is the
leading the
department?
department?
How long this your department is there in women's medicine?
Department started 8 months back, madam.
Okay, okay.
Good. They have had a palliative care unit for a long time. I remember that about 7 or 8 years back, Grace Koirula from Vellore worked there for some time in palliative care. Ahmad,
Yeah.
so 5 doctors. Who is the head of the department?
Actually, as head, we have Dr. Thomas, who is a pharmacologist. He has also did some fellowships in palliative medicine.
Okay.
3 anesthesiologists are there: Dr. Arun, Dr. Arjun, and Dr. Melvin. And then Dr. Srilakshmi from medicine department. And one Dr. Samira also from medicine department.
Good. And you have medical social workers and nurses and all that.
Yeah.
Good.
Actually, this medical college is part of Aster only. Dr. Moopen's Medical College. They have started a new project known as DM Ashwas here for the palliative medicine.
Very good. Okay, Sri.
Thank you so much, sir. Thank you so much, Dr. Ahmad. Maybe you should consider starting home-based services also. We get a lot of queries from Wayanad, so that will be wonderful to have a place where we can say they have home-based services.
This is near Calcutta, right?
Yeah, sir. Mepadi near Calcutta, 10 kilometers.
Mepadi. Okay.
Thank you. Thank you so much, everyone.
Everybody, thank you from me also.
Thank you, sir. Thank you, sir.
Thank you so much, Dr. Rajagopal sir and Dr. Sridevi ma'am, for the wonderful session. And thank you all for the participation. We are looking forward to see you on the next session. Thank you all.
Thank you, ma'am.